Bismillahirrahmanirrahim. Hadith of the day. The Prophet, peace be upon him, said, "He who does not thank the people is not thankful to Allah." Assalamu alaikum, everyone. I am Dr. Marina Akhtar, PGR Community Medicine. I am presenting this topic, mumps, under the kind supervision of my professor, Dr. Saira Afzal. Learning outlines. Introduction of mumps, epidemiology, clinical features, complications, control and treatment, prevention, recent updates, and MCQs. Learning outcomes. By the end of this presentation, participants will be able to describe mumps, epidemiology, clinical features, complications, control and treatment, and prevention of mumps. Mumps, also known as infectious parotitis, an acute infectious disease caused by RNA virus classified as genus Rubella virus of family and paramyxovirus, which has a predilection of glandular and nervous tissue. Clinically, the disease is recognized by non-sporulative enlargement and tenderness of one and both parotid glands. Incubation period is 14 to 21 days and is communicable from 6 days before to 9 days after facial swelling is apparent. It may lead to sterility, brain inflammation, and deafness. Epidemiological triad agent is RNA paramyxovirus, mumps virus, one antigenic type, rapidly inactivated by formalin, ether, chloroform, heat, and ultraviolet light. Host is human, which is who is with failure to immunize completely, children between 2 to 12 years of age, and with weak immune system. Environment. Mostly the environment is late winter and spring season, small and enclosed room, and overcrowded places. Epidemiology and the distribution with regards to time, place, and person. By time, high prevalence in winter and spring season. By place, overcrowded areas. By person, 85% infection occurs in the children under 15 years of age. Immunity is lifelong after one attack. Mostly, infants under 6 months of age are immune because of maternal antibodies. And determinants, primary and secondary. Primary determinants are causative agent is RNA virus classified as genus Rubella virus of family paramyxovirus. Secondary is overcrowding, poor nutrition, winter and spring season. Frequency. In the most part of the world, the annual incidence of mumps in the absence of immunization is range of 100 to 1,000 cases in 1 lakh population, with an epidemic peak every 2 to 5 years. The disease occurs throughout the world, although the morbidity rate tends to be high and mortality rate is negligible. Source of infection, both clinical and subclinical cases. Subclinical cases, which accounts for 30 to 40% of all cases, the virus can be isolated from saliva or from swab taken from the surface of Stenson's duct. Virus has also been found in the blood, urine, human milk, on occasion in CSF. Periods of communicability, usually 4 to 6 days before onset of symptoms and a week or more thereafter. The period of maximum infectivity is just before and at the onset of parotitis. Once the swelling of the gland has subsided, the case may be regarded as no longer infectious. Secondary attack rate estimated to be 86%. Mode of transmission. The disease is spread mainly by droplet infection and after direct contact with infected person. Incubation period is varies from 2 to 4 weeks, usually 14 to 18 days. Clinical features. Mumps is generalized viral infection. In 30 to 40% of the cases, mumps infection is clinically asymptomatic. In clinically apparent cases, it characterized by pain, swelling in either or one or both parotid glands, but it may also involves the sublingual and submandibular glands. Often the child complains of earache on the affected side prior to onset of swelling. There may be pain and stiffness on opening the mouth before the swelling of the gland is evident. Mumps may also affect the testes, pancreas, CNS, ovaries, prostate. In severe cases, there may be fever, headache, other constitutional symptoms, which may last from 3 to 5 days. The swelling subsides slowly over 1 to 2 weeks. Complications. Orchitis. Testicular swelling and tenderness denotes orchitis, which is the most common extra-salivary gland manifestation of mumps in adults. It is unilateral in about 17% of cases. High fever usually accompanies orchitis, which develop typically 7 to 10 days after the onset of parotitis. Is about 25 to 40% of post-pubertal men. Bilateral orchitis is rare. The assumption that mumps orchitis may lead to sterility is ill-founded pancreatitis. Upper abdominal pain, nausea, vomiting suggest pancreatitis. Mumps is leading cause of pancreatitis in children. It occurs about 4% patients. The complications are continued of oophorytis. Lower abdominal pain, ovarian enlargement suggest oophorytis, which occurs in 5% of post-pubertal women, usually unilateral. Meningitis. 15% of mumps patients may develop meningitis. Encephalitis. 0.02 to 0.03% may develop encephalitis. Deafness. Mumps is one of the main infectious causes of sensory neural deafness, which affect approximately 5% in 1 lakh mumps cases. Complications in pregnancy. Mumps infection in first trimester of pregnancy is associated with 25% incidence of spontaneous abortion. Although congenital malformation following mumps infection in pregnancy have not been reported. Rare complications includes nerve deafness, polyarthritis, hydrocephalus, encephalitis, cerebellar ataxia, facial palsy, transverse mellitus. Encephalitis is associated with cerebral edema, serious neurological manifestation, and sometimes death. Diagnosis. Usually physical examination, and if there is uncertainty about the diagnosis, then test for saliva and blood PCR. Treatment. No specific treatment. Patients are advised to do rest, take healthy soft diet, analgesic use for pain, and antipyretic for fever. Control. The control of mumps is difficult because the disease is infectious before the diagnosis can be made. The long and variable incubation period and the occurrence of subclinical cases make the control of spread more difficult. However, cases should be isolated till the clinical manifestations subside. Steps should be taken to disinfect the articles used by the patient. Contact should be kept under surveillance. Mumps surveillance. Case definition. WHO recommends the following case definitions for mumps surveillance. Clinical mumps. Acute onset of unilateral or bilateral tender self-limited swelling of the parotid or other salivary gland lasting 2 or more days without other apparent cause. Laboratory confirmed mumps. A patient with clinical mumps and laboratory confirmation by positive mumps IgM antibodies without mumps immunization in previous 6 weeks or seroconversion with 4 folds or greater rise in mumps IgG titer or isolation of mumps virus from saliva, urine, or CSF. Epidemiologically confirmed mumps. A patient with clinical mumps who is epidemiologically linked to a laboratory confirmed mumps case. Prevention. Mainly prevention is by vaccination. And vaccination, highly effective live attenuated vaccine is now available for prevention of mumps. Widely used live attenuated mump vaccine strains include the Jarelin, RIT, Leningrad, L, Zagreb, and Europe strain. Live attenuated mump vaccine strain used only on the limited scale include the Hoshiano, Tori, NKM. WHO recommends that Rubini mumps vaccine strain should not be used in national immunization program because of its demonstrated low effectiveness. A single dose 0.5 ml IM intramuscularly produce detectable antibodies in 95% of vaccinees. The duration of long-term immunity is unknown. It is recommended for routine immunization for children over 1 year of age, either alone or in combination with other virus vaccine, for example, in MMR vaccine, or as a quadrivalent vaccine with varicella. A second dose is recommended for children at 4 to 6 years of age, that is before starting the school. The current mumps strain Jelly has lowest associated incidence of post-vaccine aseptic meningitis from 1 in 150,000 or to 1 in 1.8 million. There are no cases of long-term sequelae associated with mumps vaccination. Countries including mumps vaccines, their national immunization programs are advised by WHO to set disease control, target control, or elimination, and to design their mump immunization strategy accordingly. Strategies to achieve mump elimination include very high coverage with the first dose of mumps vaccine, ensuring a second opportunity for vaccination, and conducting catch-up. CDC. Mumps can be prevented with MMR vaccine. This protects against 3 diseases: measles, mumps, rubella. CDC recommends children get 2 doses of MMR vaccine, starting with first dose at 12 through 15 months of age and the second dose at 4 through 6 years of age. Teens and adults also should be up to the date on their MMR vaccination. MMR vaccine is very safe and effective. The mumps component of MMR vaccine is about 88%, range 32 to 95% effective when a person gets 2 doses. 1 dose is about 78%, range 49 to 92% effective. Contraindication and precautions. Severe allergic reaction to vaccine component following a previous dose. Second is pregnancy, immunosuppression, and severely ill patient. Vaccination should be avoided or used with caution. Now comes to recent updates. Here is the article, current status of mumps virus infection, epidemiology, pathogenesis, and vaccines. Mumps is an important childhood infectious disease caused by mumps virus. The number of cases caused by mumps virus decreased steeply after introduction of mumps vaccine worldwide. In recent years, a global resurgence of mumps cases in developed countries and cases of aseptic meningitis caused by some mumps vaccine strain have renewed the importance of mumps virus infection worldwide. The performance of mumps vaccination has become an important issue for controlling mumps infection. Vaccine development, routine vaccination are still effective measures to globally reduce the incidence of mumps infection. During outbreak, a third of MMR vaccine is recommended for groups of persons determined by public authorities. And second article, here it is. Mumps in vaccination age, global epidemiology and situation in Germany. Literature analysis revealed that outbreak was facilitated by waning immunity and crowding. Nevertheless, although vaccination prevented infection, the course of illness once infected was sometimes more complicated in comparison to non-vaccinated population. High rates of complicated courses occurred and were marked by orchitis due to higher age of mumps patient. Therefore, refusing vaccination against mumps increased the risk of severe courses when living in the vaccinated population. And third article is analysis of measles, mumps, rubella, MMR titers of recovered COVID-19 patients. The MMR vaccine has been theorized to provide protection against coronavirus disease 2019. The aim of study was to determine whether any MMR IgG titer was inversely correlated with severity is recovered in a recovered COVID-19 patient previously vaccinated with MMR2. The result demonstrate that there is a significant inverse correlation between mumps titer from MMR2 and COVID severity. Now the time for MCQs. MCQ number 1. 7-year-old boy presented to pediatric OPD with complaint of pain in front of his neck, difficulty in chewing, fever, headache, malaise for 5 days. Following is the most common cause of this condition. Anyone? The answer is our topic, mumps. MCQs number 2. Complication of mumps are rare but severe. Which is the most common extra salivary gland manifestation of mumps in adult males? Answer is option C, orchitis. MCQ number 3 is mumps is a viral disease caused by RNA pyramyxovirus. Initial symptoms are not specific. They are fever, headache, body aches, anorexia. Which of the following is local symptom of mumps? Swelling of tonsils, option A. Option B, swelling of thyroid gland. Option C is swelling of salivary gland. Option D, swelling of adrenal glands. Option E, swelling of sweat gland. Answer is option C, swelling of right answer, swelling of salivary gland. MCQs number 4. If the patient is diagnosed case of the mumps, he is isolated in the separate room from other family members. He will be isolated from the time of diagnosis until how many days after the onset of parotitis? Option A, 5 days. Option B, 9 days. Option C, 10 days. Option D, 12 days. Or option E, 15 days.
B.
Yes, B. Option right answer is B. I mentioned in my slides. MCQs number 5. A patient was admitted to the chest ward suffering from respiratory tract infection. He was infected by respiratory droplets. Which of the following disease is not transmitted by respiratory droplets? Option A, chickenpox. Option 2, mumps. Option C, measles. Option D, polio. Option E, rubella.
D.
The option D is right answer. All others are infected by respiratory droplets. Poliomyelitis is also infected by respiratory droplets, but this is the least cause. Main cause is fecal contamination of infected person. MCQs number 6. Vaccination is the most effective approach in the prevention of mumps. Those who are completely vaccinated are mostly immune to mumps. The route of administration of mumps vaccine is option A, intracutaneous. Option 2, intradermal. Option B is intramuscular. Option D is intravenous. Option E is oral.
C.
Yes, C is the right option, intramuscular. MCQs number 7. Mumps infection in first trimester of pregnancy is associated with option A, congenital abnormalities. Option B is intrauterine death. Option C is decreased liquor. Option D is spontaneous abortion. Option E is low birth weight baby.
A.
Right answer is spontaneous abortion. I mentioned in my slides in complications. MCQs number 8 is for the past few years, there have been a huge number of mumps outbreaks in XYZ college of a city. To prevent from mumps, students are encouraged to make sure about which dose of MMR vaccine. First dose, option A, first dose. Option B, second dose. Option C, third dose. Option D, fourth dose. And option E, fifth dose.
B.
Option C, third dose. MCQ number 9. For how long a newborn is immunized from mumps by maternal antibodies? 4 weeks, 2 months, 6 months, 1 year, or 15 months?
A.
Right answer is 6 months. I mentioned in my slide 6 months. MCQ number 10 is a preschool child is migrated to a city with low probability of exposure to measles and mumps. The child had received 2 doses of MMR vaccine. In the current situation, further vaccination requirement of the child is should receive no additional dose. Option B is should receive 1 additional dose. Option C is should receive 2 additional doses. Option D is should receive 3 additional doses. Option E is should receive a booster dose.
A.
Yes, A is the right answer. Here's the key of MCQs. There is the reference of my presentation. And here's the link of our YouTube channel. And thank you.